Okay. Good morning. Thank you everyone for joining today's APHRS Education webinar, ICD Module Part 1. My name is Jeremy Yu, the Regional Education Manager at Abbott Medical. It is my pleasure to be the moderator of this section. After today, ICD Part 1, if you also attend ICD Part 2, which is on 19th of September, then you can apply for a certificate of attendance from the APHRS. The pacing and CRT modules have been completed earlier. The video on demand will be available on the APHRS website next week. Today we have invited 4 experienced speakers, including Dr. Pauli Cha from Singapore, Dr. Catherine Fan from Hong Kong, Dr. Bao Yu from China, and Dr. Arizava Suwanogu from Thailand. If you have any questions wanted to ask our speakers, please type them into the chat box in your control panel. We will have time for Q&A after each section. So now I would like to introduce our chairperson, Dr. Pauli Cha. Dr. Cha is currently a senior consultant and head of the Department of Cardiology in Tan Tock Seng Hospital, Singapore. He is also the head of the Arrhythmia, Cardiac Electrophysiology and Pacing Surface. His special interests include cardiac arrhythmias and device implantations. He has published extensively in these areas in local and international medical journals. Hi, Dr. Cha. May I invite you to deliver an opening message? Thank you.
Thank you very much, Jeremy. A very good morning to our global friends and colleagues. A warm welcome to part 1 of the ICD module, the APHRS Cardiac Rhythm Device Therapy webinar series. I would like to thank APHRS for putting together this wonderful program, as well as Abbott for all the necessary support. We have 3 very distinguished speakers this morning. At the end of each lecture, we will have a 5 minutes question and answer session. So please do submit your questions online. I do apologize in advance that in the interest of time, we probably will not have the opportunity to answer all your questions. Without further ado, allow me to introduce our very first speaker. There'll be a slight change in the sequence of the lectures. We will start with Professor Bo Yu.
Hey, good morning. I can see Dr. Catherine Fan.
Hi, sorry about that. I have some difficulties connecting this link, the Zoom meeting. Sorry about that.
But now your audio and camera is great. So can you do the first, yes, very good. Would you like to do the first lecture for us?
All right.
Okay, I pass it back to you, Dr. Cha.
Yeah, sure. So a warm welcome to Professor Catherine Fan, Consultant Cardiologist in Cardiac Medical Unit, Deputy Hospital Chief Executive of Grantham Hospital in Hong Kong. She will discuss sudden cardiac death and guidelines for ICD implantation. Professor Fan, please.
Thank you. Thank you for your kind words, and let me try to share the screen first.
Yep, can you find the share screen button, which is on highlighting green color? From Dr. Yu?
Yep, sure.
Hey, hi, Dr. Yu.
Yeah.
Good morning.
Good morning.
Yeah, I'm sorry about that because of some of the technical issue. So, would you mind to deliver the first lecture for us?
So
Okay.
maybe let me introduce Professor Yu first.
Yes. So I'm
apologies to our participants for the slight technical glitch. So we'll start with Professor Bo Yu. Professor Yu is Deputy Director of Cardiology Department and Professor of the First Hospital of China Medical University. He will share with us his invaluable insights into the ICD implantation procedure. Professor Yi, please.
Can you see the screen?
Yes.
Yes.
Dear Chairman, ladies and gentlemen, it's a great honor for me to have this opportunity to have these lectures. So today I will talk about the ICD implantation procedures. There's a saying, device implantation is the time when you embark your patient in a lifelong therapy. So it is time to think about the future. Whenever you implant ICD.
Sorry,
excuse me,
Dr.
Dr. Yu, can you please try to share your screen again? So
Okay.
my side cannot see the slides. Is it the same for you, Dr. Cha?
Yes, I can't see it.
Okay.
Can you see it?
Yes, now it's great. Thank you.
Okay. So first, the overview, the current status of ICD implantations. So this procedure is very similar to pacemaker implantation. Anyone, if he is capable of implanting a pacemaker, can insert an ICD, but there are many differences existed. So first one, the device and the least choice. For the ICD, you have to ask the patient to decide whether single or dual chamber ICD or single or dual coiled leads. Also, intravenous or subcutaneous ICDs or WCD. And also, you may consider about the maximum energy of this ICD and MRI compatibilities, also telemetry. Other thing you should think about is the implantation techniques. So it is different from pacemakers. When implant ICD, you may prefer the left side exercise and using axillary veins. And also, we want to have a better sense locations. For the ICD patients, most time the patients are in the heart failure conditions, so they are sicker. The complication rate of implantation usually is higher. And if you want to do the DFT test during the ICD implantations, we need more physicians and technicians back up. And for the ICD leads, the failure rate is usually higher. Be careful for the manipulation of fixation, and also for the pocket making, the pocket erosion rate is higher. Usually, you may think about contoured or thinner shape ICDs, and the pocket usually in the deeper layer. For the ICD implantations, we divided it into 3 stages. The first one, pre-implanted planning. The second one is peri-implantation and also post-implantation follow-up. For pre-ICD implantation, you have to do complete clinical evaluation of the patients, including history, physical examination, also the history of arrhythmia, whether the patient has SVT, sick sinus syndromes, AV blocker, or VTVF. The patient may have ECG or electrophysiology study data, also angiographic data, and echo. So for the ICD patient, the important things you must know: underlying heart disease and left ventricular function, because of different heart disease, the ICD choice may be different. And also you may consider about the patient is for primary or secondary prevention. And another thing you need to do before the ICD implantation, you may discuss with the patient and the family. In China, most time we need to talk with the family and sign the informed consent paper. That's very important. For pre-ICD implantation, you have to talk with the patients about the device choice and the lead choice. For the device choice, for the single chamber or dual chamber ICDs, you may consider about need for atrial pacing, or whether the patient have impaired AV conduction, and also the patient, whether the patient is in the hypertrophic cardiomyopathy, and also whether the patient needs CRTD or MRI compatibility and the telemetry at all. As you know, the first ICD was implanted in 1980s. During that time, the ICD is so big, but in nowadays, the ICD changed to a smaller, the size reduced, and the shape changed to pocket friendly. So you may choose the device according to the patient body shape. For the lead choice, you may consider whether it's a single or dual coil, or DX lead, or active or passive lead. As for SSD or TV ICD indication, another doctor will give the lecture. I will skip this part. In some patients, you may also consider WCD. WCD used for bridging a decision for appropriate ICD implantation, such as a patient in post-MI or after coronary revascularization or new diagnosis of dilated cardiomyopathy. For ICD selection, for single or dual chamber ICD, are there any difference from two important clinical trials? We know from MEDIT2 trials, 8 years follow-up. For the mortality, the single chamber ICD is better than the dual chamber ICD or non-ICDs. Another important clinical trials, David trials, it shows for the cumulative MIS events, the single chamber ICD is better than dual chamber ICDs. So a single chamber ICD is a better choice for most patients. Maybe a dual chamber ICD, you may consider it in a dual chamber ICD sometimes has a high rate of complication and more costly. So right now in this stage, most patients may be considered for single chamber ICD. As for the lead selection, as you know, the lead developed in 3 stages. First and the second generation lead is the epicardial lead. The third generation lead start from 1993 is endocardial leads. For endocardial leads, it can be divided into an active or passive fixation, a single or dual coil, and for the pins, it can be divided into a DF1 or DF4 connectors. ICD leads is different from pacemaker leads. ICD leads have a higher defect rate. From a study, there's nearly 1,000 ICD leads. They follow up this leads for 10 years. You can see at 10 years, almost 20% of the ICD leads failure. So you may consider the extraction of ICD in the future. So that's the biggest part of ICD lead. Actually, there are 3 most important parts for the adhesion of ICD lead for subclavicular veins and ICVC, also the right ventricular apex. So whenever you withdraw this ICD leads, they may have some problems. So in 2017 HIS guidelines, in some situations you may consider to withdraw the ICD leads, not all of the ICD leads. As for the single or dual chamber ICD leads, there are some studies compare the single coil or dual coil ICD leads. So at this stage, no benefit of dual coil over single coil ICD leads. Theoretically, dual coil leads have a better vector for defibrillation and a better DFT. But there's some different studies showing the dual coil lead may slightly has a higher first time shock success rate. Also, the dual coil leads are more difficult and dangerous to extraction. So at this stage, dual coil leads only be considered in patient expected in a high DFT test. Right side implantations, as you know, if you implant an ICD in the right side, the DFT may be increased 1 to 2 joules. And also ARVC or ARVD, very large hearts. So when you choose ICD leads, most patient, a single coil lead is a better choice. Pre-operation preparation. If the patient, you want to give the patient DFT test, you may ask the patient to not have food or drink 6 hours before the procedures. So routine blood check, sieving and cleaning, and also intravenous cannulation on site of implantation, usually in the left side. In case of venography for difficult punctures. Also, you may consider the anticoagulation status. In some patients with atrial fibrillation or valve disease, the patient may taking warfarin or NOAC. So during this time, you have to talk with the patient or analyze the clinical data of the patient. If the patient embolic events rate, annual risk of embolic events greater than 5%, you better not stop VKA or non-ACT. Also, during or before the procedures, you may give the patient antibiotics. So there are 3 most important clinical trials showing pacemaker and defibrillator surgery without interruption of anticoagulation may be benefited for the patients. Pre-operation cath lab preparations, just like the pacemakers, but you have to have an external defibrillator connected and also PIC cables connected, and you need qualified staff present. During the implantation, as for the approach and exercise, left side approach is preferred. As I said, right side approach will increase the DFT. And for venous exercise, we have 3 choices, cellular, subclavian, or axillary. The axillary is preferred. You can see if you're using axillary veins, you have a less chance to damage the leads. If you have some difficulties, you may give the patient a venogram and a fluoroscope gad as required. And also left side approach, you can see the angulation of the leads is smaller in the left side than the right side. For venous access and ICD lead failure, as you know, ICD lead failure rates about 20% in 10 years. So there is a study in the EIC Congress 2018. You can find X-ray puncture and syphilic cut down have a better results. In a difficulty lead implantations, you may need a venogram to find the stenosis or occlusion of SVC. And also you can find some congenital abnormalities such as left side SVC or dextrocardia. That's very difficult to implant leads. As for the position of RV leads, pre-implantation, check helix mechanism and make sure helix withdrawn in case entangled with muscle or tricuspid walls. Sometimes we can have these problems. And during the implantation, you're gently handling of leads you have two choices. Either put the leads into RV apex. It is easier, good signals, and good vectors. But compared to the middle or lower septums, if you put these areas, you may have less likely perforations and more physiological pacing, especially for AV block patients, and also for the CRT patients. And fix it, these according to the instruction. Usually we turn the leads 12 to 15 rotations and ensure adequate slack in case the lead dislocation. As for the ideal ICD lead locations, there are important studies, septal studies showing no difference in sensing or pacing characteristics, no difference in arrhythmia detection and determination. So you can put the ICD lead anywhere you can find. For the positioning of RV lead, the most important things we need the sensing is at least the R wave, at least the 5 for the bipolar. As for the pocket preparations, we have two choices, pre-pectoral or submuscular. It is different. For the pre-pectoral, it limits patient trauma, shorter hospital stays, and less complicated procedures. But you don't want the pocket like this. For the submuscular pocket, it's good for low body weight patients, more cosmetic, and potentially reduce infection, and may lower DFT thresholds. And for the lead suture, use only non-absorbable sutures, loop through tissues first as leaves, and do not tie a ligature directly to the lead body in case you damage the lead. For lead connection to device, this is very important because ICD leads usually for the DF1 connection, you have 3 pins. You have for the dual chamber or CRTD, you have 4 to 5 holes. So make sure you put the right holes, put the pins in the right holes. So verify serial numbers for each lead and ensure boards in device header are clear. Special attention in DF1 because in DF4 you only have one choice. For place supplied torture wrench in grommet proper to insert lead into device ports. Visualize lead connector pins past the set screw blockers. If you are not sure, you can check the insertion under fluoroscopy to make sure the pins through the holes. You can also check connections from programmers through the impedance. You can know if the patient is the high impedance, that suggests it is not properly connected. If you're in low impedance, that may suggest there is an open circuit. For lead and device placement, that's also very important. You have to rotate the leads and the ICD in a proper position. Whether you should put rinse the pocket with antibiotics, there's from Medtronic, they have Tetrix absorbable antibacterial envelope. In 2018, they published rapid studies showing with this envelope, it can decrease the infection rate significantly. Then you close the device pocket just like pacemakers. Is there a need for defibrillation testing? For DFT, confirms appropriate sensing and efficacy of the device, just like a pacemaker implantation, you need to check sensing and pacing. But in modern era stage, the ICD usually has 40 joules maximum. So the failure risk is very low. So if you use high power ICDs, probably you don't need a DFT test. During the DFT test, you need anesthetize the patients. And this DFT test may cause traumatic or proarrhythmic, especially for the heart failure patients. And also the DFT does not predict the future efficacy of the ICD. So implanting testing should be done with an active device, and ICD should be targeted. So there's a guidelines in 2015 from HRS. In the following situations, you may do the ICD DFT test. So for the defibrillation efficacy testing is recommended in patients undergoing a subcutaneous ICD implantation. That's a class 1 recommendation. For transvenous ICD implantations, it's reasonable to omit defibrillation efficacy testing. It's a 2A recommendation. And defibrillation efficacy testing is reasonable in patients undergoing a right pectoral transvenous ICD implantation or ICD pulse generators changes. The DFT test is 2A recommendation. For post-transvenous ICD implantation, in the Western countries, usually they ask the patient have a bed rest for 2 hours. But in China, usually we recommended the patient to have a bed rest for 24 hours. I don't think we have clinical trials to make sure how long how long is a better time for the patients. And I watched it in the United States. They usually, after 2 hours, give the patient cardiac X-ray pictures to make sure the lead in a good position, then let the patient go home. And also before patient leaving, they check the pacing condition. And also they may give the patient the pressure dressing if thought of a risk of hematoma. And in China, the patient usually stayed in the hospital for 3 to 5 days, but in the United States, they may go home in the same day. As for the complication of implantation ICDs, during acute stage, the complication rate from NCDR ICD registries, the complication rate is about 4 to 6%. The mortality rate is less than 1%. For the pacemaker, I don't think we have any, the mortality rate probably less than 0.1. But for the ICD, because the patient is very sicker, so usually you can have some patients died during the procedures. And the complication almost the same as pacemaker, but the perforation rate and the tamponade may be higher, and also the lead dislocation rate may be higher. For the late ICD complications, including infection, pocket hematoma, lead dislocation fracture, and venous thrombosis, especially for the CRTD patients, usually in the same veins, the patient may have 3 to 4 leads in the same veins. They may cause some problems. As for the follow-up recommendations, advice regarding wound management, you may ask the patient to change to watch the wound every 2 or 3 days. And in China, we don't have TCU. We usually send the patient to CCU for 24 hours. Then we ask the patient to follow up to the clinic every 3 to 6 months. When the patient gets shocks, they must go to the clinic immediately. Also, during the follow-up stage, don't forget etiology treatment and anti-arrhythmia therapies. There is a study called optical sewing. If you give the patient a beta blocker plus amiodarone, it may decrease the ICD shock and electrical storm. So for the ICD techniques, I make conclusions for the past time and present time. The comparison, we can see the ICD is smaller right now, and it's a first-line therapy for the VTVF. And also we use transvenous single incision and local anesthesia. Often one-day, same-day case procedures, less complications compared to the older states, the perioperative mortality up to 9%. And programmable therapy options, you can program the patient with ATP, and actually will give patient painless treatment. And as for the single ICD choice, I think during this stage we have more data showing single chamber ICD may be better for most of patients. A single coil at least may be better for most of patients. And right now the ICD longevity is over 10 years. I think that's my talk for today. Thank you for everybody. Thank you, Chairman.
Thank you very much, Dr. Yu, for your sharing on the tips and tricks of implantation. Hey, hi, Dr. Chan. Do you have anything you would like to add to this topic?
Thank you very much, Professor Yu, for sharing your invaluable insights. Maybe just a quick question. In your experience and practice, do you routinely stop the direct oral acting anticoagulants before ICD implant, or do you allow the patients to continue on this anticoagulations?
Yeah, I think from the study showing for the anticoagulant and also the antiplatelet during ICD implantation, if the patient in a very high risk of thrombosis, like 5% of risk, we will continue to the antiplatelet and anticoagulation. If the patient is low risk for the coronary heart disease, for the dual antiplatelet therapies, if the patient in the primary prevention, we may stop everything. For the secondary prevention, if in the high risk, we will continue to the dual antiplatelet therapies.
And I can see there is a questions from our audience. He asked about the Helix mechanism, or do you prefer to use active or passive lead for the ICD lead? Dr. Yu, any comments on
that? I'm not sure about these questions. So for Helix mechanisms, that means a passive or active leads?
Yes, I think. Yeah, which lead you usually prefer to use for your patient?
Okay. I think for me, after 25, when we have the active leads, including pacing lead, I always select active leads because it's easier to withdraw the lead in the future. So as I said in the beginning, when you implant a pacemaker, you have to think about the future of the patient. So for the ICD leads, you may have a 20% failure rate during 10 years follow-up. If the patient can survive longer than the 10 years, the 20% of the patient have faced the problem of withdrawal of lead. So active lead is a better choice, I think.
Thank you, Professor Yu. I think in the interest of time, we'll now move on to the next lecture. Please allow me to introduce Professor Catherine Fan, Consultant Cardiologist in Cardiac Medical Unit, Deputy Hospital Chief Executive of Grantham Hospital in Hong Kong. She will discuss sudden cardiac death and guidelines for ICD implantation. Professor Fan, please.
Thank you. My deep apology for the my technical issues, but I hope you can see. Can you see my screen?
Yes, we can.
Great, thanks a lot. My given task today is talk about sudden cardiac death and ICD guideline. Actually, this is a very huge topic, and I'm trying to squeeze pick up some of the salient points, and hopefully we'll have some sort of in-depth discussion afterwards. So sudden cardiac death or sudden cardiac arrest and its most common consequence of sudden cardiac death actually account for about 50% of all cardiovascular death worldwide. Survival statistics for the out-of-hospital cardiac arrest remain very disappointing, approximately 10% overall survival rate. And the greatest challenge we're now facing is trying to identify the relatively small high-risk subgroup concealed within the large general population who have no identified disease but are at risk of sudden cardiac death at their first cardiac events. This two diagrams actually comes from the 2017 AHA-ACC HIS guideline. And indeed, the showing that the sudden cardiac incidence is highest in is slowest in the general population group considering the denominators. But our task is now trying to find the high risk group, as well as we now know that it's the heart failure patient or cardiac arrest survivor, and looking out for risk stratification. Is this the high risk group we try to identify, and how to improve their outcome? The major etiology of sudden cardiac death are listed here. Mainly predominantly is ischemic heart disease or any involving the coronary or the aortic disease. The non-ischemic heart disease are listed here, like dilated cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic RV dysplasia, and some congenital heart disease, especially the post-repair TOF or the Epstein patient. Of the therapies currently available to prevent sudden cardiac death, we know that ICD is now by far the longest standing and best supported by data from clinical trial and regulations. And how the ICD function, I think if you, this will be go into more details either in today's and then the subsequent lectures about 2 weeks later. But very briefly, it monitors the heart rhythm continuously. And when programmable rate is met, or when what physician define as tachycardia, it will detect it either VF or VT. If programmed, sustained SVT discriminator is on, it will further classify the tachycardia SVT or VT, and if confirmed, the therapy in form of ATP or shock is being delivered. The multiple randomized multi-center clinical trials have contributed and established the role of ICD as mainstay in treatment of ventricular arrhythmia and sudden cardiac death prevention. In this diagram, you can see the first, those studies are shown here are the sort of landmark study for establishing our secondary prevention criteria. And those in the middle, as highlighted by the yellow arrows, are the patients who have heart failure or left ventricular dysfunction alone, but no documented ventricular arrhythmia beforehand. And these are the high-risk group we indicated as primary prevention. These are the few studies actually indicate, well, not that significant benefits from ICD, namely those who require revascularizations and shortly after coronary interventions. Now, this is a two landmark trials on primary prevention ICD, and both of them use left ventricular dysfunction as the main criteria. In the MEDIT-2, published in the New England Journal 2002, is ejection fraction of less than 30% in MI patients. And in the SCUT-HEF trial, prophylactic patients, New York Functional Class 2 or 3 with ejection fraction of less than 35%. In this group, they include both ischemic and non-ischemic. Both demonstrated significant improvement and reduce of sudden cardiac death in the ICD group. Accordingly, over the years, guidelines has been written and updated. And I'm going to concentrate a bit more on the most recent one, on the 2017 AHA-ACC HRS guideline for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death. This is a very well-written paper, and it actually starts with a lot of therapies recommended when we are treating patients considered high risk of sudden cardiac death. Mainly, we have to titrate heart failure therapy, evaluate for ischemic heart disease, any possible anomalous origin of coronary arteries, and the further additional management of the monomorphic VT refractory antiarrhythmics, and whether we should consider catheter, surgical ablations, and even autonomic modulations. These are all the adjunct therapy or you need to think about if you have a patient being considered with heart failure or ongoing ischemia and consider high risk of sudden death. And I'm going to pick up just the two main group of patients we considered a high risk of sudden cardiac death. And this guideline actually spent a lot of pages and content on this specific disease state. The first of all is the ischemic heart disease. Here listed the secondary prevention of sudden cardiac death in patients with ischemic heart disease. And it's all pretty well, I will not go into details, but it's all pretty well written out, either survival of sudden cardiac death or hemodynamic unstable VT. You have to look at the risk. All these are an ischemic heart disease with unexplained syncope and inducible VT on electrophysiology. These are all class 1 indication. And this is the flow chart. So either it's a sudden cardiac death survivor or documented monomorphic sustained VT or patient with cardiac syncope with low ejection fraction. So this is how the secondary prevention of ischemic heart disease flow diagram is shown very well, simple and illustrated here. The primary prevention of sudden cardiac death in ischemic heart disease are listed here. Basically, if you look at ejection fraction of less than 35% or less due to ischemic heart disease who are at least 40 days post-MI and at least 90 days post-revascularization, New York Functional Class 2 or 3 despite guideline-directed medical therapy. The second one is ejection fraction of 30% or less, ischemic heart disease who are at least 40 days post-MI, at least 90 days post-revascularization, this time New York Functional Class 1. This is also given a Class 1 indication in this guideline. On top of that, we need to think of, if you think of patients are significantly high risk due to VA, then you need to think of the values. You need to really go over the values of identifying high-risk patient. Then here is the non-sustained VT due to prior MI, ejection fraction 40% or less, and inducible VT or VF at EPS. So this is also another Class 1 indication. Kindly remind you that all Class 1 indication has this additional criteria of meaningful, if you think that there's a meaningful survival or greater than 1 year is expected. 2A is patients of ischemic heart disease, functional class 4, who are candidates for cardiac transplant on an LVAD. So here, ICD is considered reasonable as a bridge to transplant or mechanical circulatory support. However, for class 3, which is not indicated with no benefit, are those patients who are functional class 4 and medical refractory heart failure, who are not also candidate for transplant LVAD, or even CRT defibrillator that incorporate both pacing and defibrillation threshold. So class 4 with no indications of further advanced heart failure therapy is a class 3 indication. And this actually, I'm going to then go to talk about probably associated with under the heart failure section. They look into patients with reduced heart failure, again, similarly for waiting heart transplant, who otherwise would not qualify for ICD, such as class 4 use of inotropes with plan to discharge on ICD is reasonable is a 2A. And similarly, for a 2A indication 2A is LVAD with sustained VA ventricular arrhythmia. ICD can be beneficial. ICD use after heart transplant is also listed in patient with probably starting to have dysfunctional graft or severe allograft vasculopathy. So this is the primary prevention of sudden cardiac ischemic heart disease in the flow diagram form. I went through the fundamental class 1 and 2, non-sustained VT with ejection fraction 40% inducible VT, and those with functional class 4 but eligible for advanced heart failure therapy. On top of that, if those patients have recurrent VA, there are also criteria of under indication 1 of using medical therapy or catheter ablation. However, for recurrent VA with ischemic heart disease, again, in patient in excessive VT or VF, an ICD should not be implanted until sufficient control VA is achieved to prevent repeated ICD shock. So this is a harmful class 3 indication. On top of that, they also have a reminder that if patient with ischemic heart disease sustained monomorphic VT, coronary revascularization alone is an ineffective therapy to prevent recurrent VT. Now we change to non-ischemic cardiomyopathy. Similar to the ischemic cardiomyopathy group, if for secondary prevention are those who have documented abort sudden cardiac arrest due to VT-VF or hemodynamic unstable VT. For 2A is an non-ischemic cardiomyopathy with syncope presumed due to VA who do not meet the prime indication for primary prevention ICD. Sometimes we consider, if you are considering ICD or even an electrophysiological study for risk stratification may be beneficial. For those who survive a cardiac arrest, sustained VT, or symptomatic VA who are ineligible for ICD due to limited life expectation or functional status, amiodarone is to be considered for prevention sudden cardiac death. So 2B for this indication if you have to consider oral medical therapy for those who are eligible for ICD. Coming to primary prevention of non-ischemic cardiomyopathy, similar to the ischemic class, but this only include class 2 to 3 New York functional with ejection fraction 35% despite GDMT. So this is given a class 1 indication. And then under 2A, they look into patients with lemon AC mutation who have 2 or more risk factors, such as non-sustained VT, ejection fraction less than 45%, non-missense mutation, and male sex. So ICD can be beneficial in this group with a genetic condition of lemon AC mutation and ongoing left ventricular dysfunction. Functional class 1 is given a 2B in this guideline with ejection fraction less than 35%. And for those who are medication refractory heart failure, functional class 4, who are not candidates for any advanced heart failure therapy, such as heart transplant, LVAD, or even CRT defibrillator, ICD should not be implanted. So advanced heart failure class 4, not eligible advanced heart failure therapy is given a functional class 3. So for those with the recurrent VA in the non-ischemic group, again, amiodarone sotalol can be considered, and beta blocker, and the catheter ablation. Both of these receive a 2A indication for recurrent VA in patients with non-ischemic cardiomyopathy. So in this flow chart in the guideline, they have incorporate both secondary and primary prevention. It looks a bit busy, but if you're following the squares consecutively, it's actually pretty well defined in this flow diagram. How about the European guideline? This table actually gives us a direct comparison of the ESC guideline and the US guideline. Essentially, New York Functional Class 1 and non-sustained VT and inducible VT during electrophysiology study is not recommended in the ESC guideline, but it was this kind of functional class 1 and the class 1A and class 1B respectively in the USA guideline. The time after MI is also different, and the US guideline have also additional recommendation of more than 3 months if after coronary revascularizations, and more than 3 days if non-sustained VT and inducible VT-VF. For the non-ischemic cardiomyopathy, similarly, the class 1 is not recommended, but in the US guideline, it was given the 2B of level C, evidence of level C. So this is more or less just the major difference between the two ischemic and non-ischemic heart failure group in the USC and the ESC and the US guideline. Well, a very quick summary. The major randomized control trial have clearly established mortality benefit or ICD place for primary prevention. It's a class 1 indication with the highest level evidence. The patient with heart failure and left ventricular ejection fraction of less than 30% up to 40%, as long as more optical medical therapy and a reasonable expectation of meaningful survival of more than 1 year. And this including patient with ischemic and non-ischemic cardiomyopathy, reduction in mortality from ICD ranges from 23 to 55%. As a result, over the past decades, use of ICD for primary prevention of sudden cardiac death has become an important part of management of high-risk patients with severe left ventricular dysfunction. But as times go by, actually with evolution of technology and practice, we are seeing a lot of changes in technology and clinical practice. And I would like to use the next 5 to 10 minutes just to go over very quickly what are we facing right now in our clinical practice, and some further thoughts on the possible gaps between clinical practice and the guideline-based recommendation. So essentially, from strategy to reality, it's challenging to generalize finding from randomized clinical trials to clinical practice in the real world, because we are seeing different groups of patients. And we all know that patients in the elderly group, patients have other comorbidities such as chronic renal disease or other comorbidities. Most of them are not included in the controls setting of the clinical trials previously used to establish our clinical guidelines. For example, using the non-ischemic cardiomyopathy, is actually there's a paucity of data. The current guideline recommendation for primary prevention in non-ischemic cardiomyopathy are mostly based on the meta-analysis of small trial or a subgroup of an analysis in the larger trials, such as the SCUT-F. Medical therapy and CRT have changed dramatically the prognosis and outcome of patients with heart failure and non-ischemic cardiomyopathy. And in the face of important reduction in cardiovascular mortality, sudden cardiac death reduction contribution is diminished. And the role of non-selective ICD implantation in non-ischemic cardiomyopathy, sorry, my typo, is currently debatable. This comes from the Dana study. This study was published in 2016, just about 4 years ago, and looking into ICD implantation in patients with non-ischemic systolic heart failure. They have randomized patients on to non-ischemic cardiomyopathy and already on medical therapy and CRT. They randomly assigned from ICD to no ICD, and the primary outcome is all cause of death, a secondary outcome of sudden cardiac death and cardiovascular death. And in this group of patients, the overall left ventricular ejection is very poor, 25%. The QRS overall average is prolonged in 146. And you can see that this is a study with a very, very high compliance to our standard heart failure regime. The ACEI or ARB percentage is approaching 97%, as well as beta blockers approaching 92%. And just under 60% of this group patient received a CRT. So this group patient reflecting more of a nowadays guideline-based heart failure patient. And in this report, there's no difference in all-cause mortality in the Danish study. Even when we look at the secondary outcome, there is a reduction of sudden cardiac death in ICD group. But for cardiovascular death, 31% were actually not cardiovascular, and the arrhythmia event rate was lower than predicted. And there's no difference in patients with or without CRT therapy. But out of this study, if they look into further sub-analysis, they identify that patients of the age of less than 60 years old actually will derive benefit from ICD therapy. So this actually highlights the need for risk stratification tests outside of just LVEF to identify subgroups with non-ischemic cardiomyopathy or multiple medical therapy who benefit from an ICD. The 2017 guideline actually acknowledged Danish study, and but they actually go on further said that there's other meta-analysis which however does favor ICD in non-ischemic cardiomyopathy, and that's why they still keep the current recommendation as stated. Another study just published for the prolonged long-term follow-up of the SCUT-HEF trial just earlier this year in the JACC. They also find that the long-term ICD benefits vary according to the heart failure etiology and New York functional class. And the most benefit comes from those who are ischemic heart failure patient and those who are New York functional class 2 symptom at trial enrollment. So interestingly, beyond year 10 of ICD therapy, both the ICD and the amiodarone seems to converge together and have the similar results after on long-term follow-up. So like the question of whether we can just use left ejection fraction alone as parameters for arrhythmia risk stratification. We know that not all patients with low ejection fractions, including the original legacy trial, derive benefit from primary prevention. Lack of appropriate therapy in majority of patients with primary prevention ICD before dying of heart failure or other non-arrhythmia cause. And yet more than 50% occurrence of sudden cardiac death in normal, mild, or moderate depressed ejection fraction of more than 35%. So this, I think, I'm sure our panelists or the cardiologists do have similar experience of what we are facing currently right now in the real clinical practice. And what's more, the changing outlook of our heart failure patients because of the new therapy or additional CRT and appropriate revascularization of patients. And remember, the current indications for implanting ICD for primary prevention sudden cardiac death was based on clinical trials 15 to 20 years ago. This diagram is very interesting. Actually, it shows it's an analysis of over 40,000 patients with HFrEF enrolled in 12 non-ICD clinical trials. As a result of gradual introduction of ACI, ARB, beta blockers, mineralocorticoid receptor blockers of subsequent drugs, there's a significant reduction of 44% in rate of sudden cardiac death across this trial was observed. And the annual rate of sudden death per 100 patient year decreased from 5.4 to 3 in the long term. So this actually may have some impact on our further risk stratification of heart failure patients. So the question is there still survival benefit of primary prevention ICD in systolic heart failure? After the publication of the Danish trial, lots and lots of meta-analysis based on these questions was published. So looking at the ischemic versus non-ischemic, here the Danish trial is also included in the non-ischemic cardiomyopathy. This shows does have some benefits in ICD therapy. Another published in the BMJ Open of 5 randomized controlled trials of 2,500 patients or so. Again, they look at it, again, it seems under all groups, mortality benefits are again in the whole spectrum of patients in ICD therapy. Other meta-analysis show here, Again, significant 23 reduction of all-cause mortality to 25% in these two studies. So it is in the guideline that stated that although the Danish trial does have significant results, based on all this meta-analysis, they still keep the current indication in non-ischemic cardiomyopathy. Other risk stratification have been proposed and put forward, such as MRI imaging for the scar imaging and risk stratification. This is another meta-analysis published from the Korean journals, again showing some benefits of a CMR identification. And some of the recommendation proposed, other than identify myocardial fibrosis, you go use a biomarker such as a CRP and NT-proBNP. The rest of the guidelines actually go on to other clinical entities of management of ventricular arrhythmias as shown here. I'll go through very quickly through the slides, showing you the ARVD. This is, again, very detailed from investigation management, and this is the one on the ICD therapy. Hypertrophic cardiomyopathy. This is a frequently encountered clinical problems, and do read through the guideline because they do write out, bring out very in details. Again, no benefit of during a electrophysiology study, and in those with the identified genotype but absence of sudden cardiac risk, ICD should not be implanted. Others would be long QT syndrome shown here, Brugada syndromes, adult congenital heart disease, another group that we should not forget because they do have high risk of, some of them have high risk of frequent VAs, especially the TOF being mentioned here, and TOF who presented with syncope and ventricular dysfunction. They do also go on to talk about other transvenous ICD rather than transvenous ICD, such as the subcutaneous implantable cardioverter defibrillator. They got their criteria here, such as inadequate vascular access at high risk for infection or pacing for predictivity, or pump of CRT is not needed. And the other one is the wearable cardioverter defibrillator. I don't think it's currently available, or maybe in isolated unit overall in the Asia region. But it's really for those who are considered at risk of sudden cardiac death, but beyond the, but was still not out of the 40 days from an MI or post 90 days after revascularization. Or those who require removal ICD but still at risk. So these are the two non-transvenous ICD recommendations from the. Also, terminal care is essential for the patient with severe heart failure and not eligible. And the other thing they talk about is ICD termination at the end of life care. So this is also quite important, and this is outlined in the guideline as well. So the following actually is the last paragraph from the guideline, and they do recognize and acknowledge evidence of gaps and future research needed. So they still want to better identifications of patient likely benefit from ICD, some information on the subgroup not represented in the pivotal ICD groups, as I mentioned, high risk of identification and treatment of high risk of sudden cardiac death not identified by current ICD eligible criteria, and better risk stratification. And so they have whole lots, but I pick out some regard with specific reference to ICD therapy. Future risk stratification model will be needed, and we need adequately powered randomized study to continue our search for identifying high-risk patients with requiring of sudden cardiac death with appropriate ICD therapy. This is another algorithm published just earlier this year regarding ICD candidate, but I'm sure the rest of the speaker on today or in the next ICD lecture will go through this in more detail with you. So in conclusion, what is clear is that ejection fraction alone is likely not enough to make judgment regarding the ICD implantation. We need more information on long-term mortality when defining prognostic utility using risk score or future study or trials. Without this data, I'm afraid practice guideline will remain unchanged, and it will be hard, if not impossible, to deny eligible patients the option of ICD implantation. So future efforts should be focused on refined methods of selecting patients at risk of preventable sudden cardiac death more simply than just left ejection fraction. It's crucial for the development of cost-effective prophylactic ICD therapy aimed at closing the gap between scientific evidence and the limited resource of a healthcare system worldwide. So finally, just the last advice. Guidelines are here to guide, but patients and physicians decide. So informed decision-making is very important between you and the patients when deciding ICD implantation. Thank you very much for your attention. Thank you.
Thank you very much, Dr. Fan, for your clear and informative lectures on the updated guidelines. Hi, Dr. Cha. As Dr. Fan mentioned about ESC and US guidelines, what about the practice in Singapore? Usually, which guidelines you follow?
Yes, Singapore being a very small country, we don't have our own local guidelines, obviously. Traditionally, we have always adhered to the American HRS guidelines, but I think we all are aware that the Europeans seem to be more prompt and regular in their guidelines review. So over the last few years, we do routinely refer to the European guidelines should we come across specific patient populations in which we need some advice or guidance on how to go about recommending ICDs or not. But I completely agree with Prof. Fan in her closing remarks that at the end of the day, guidelines are simply guidelines. We really need to sit down and discuss with our patients, and especially in Singapore's context, patients' family members as well, to discuss the risks and benefits of ICD implantation as well as the follow-up. So that's in a nutshell how we practice in Singapore.
Thank you.
Thank you.
Prof. Fan, I think we have one question from a participant. In your own personal practice, are there any specific patient groups that you would definitely recommend a primary prevention ICD?
Well, I do have a lot of, I do look after a lot of heart failure patients as well. And it's always a mixed feeling when you try to refer up to the guideline and then the paper, and then you got the other rest of the studies. But I think the heart failure patients do have risk, and but especially in the less severe of the functional class 2 or 3, because by the time they reach class 4, their mode of death probably switch from ventricular arrhythmia, sudden cardiac death to pump failure. So sometimes it's quite difficult to convince the patient who are in group 2 or, well, mainly group 2 actually, that they need an ICD for protection. But I do put an ICD in more heart failure patients, definitely.
Okay. We have another question from a participant. In your practice, is there any particular score that you use with regards to estimating 1-year longevity in your patients prior to deciding whether to implant an ICD or not?
Well, there are the recommendation using the heart failure score. And if you use the Seattle heart failure score, they actually, by adding the ICD or other device therapy, actually they can change the estimation quite significantly. So sometimes I do use the heart failure score to discuss with them and show them the sort of the overall data. But again, at the end of the day, is really you have to sit down and discuss with the patients and the family the indication of the ICD, I think.
Okay.
Thanks very much.
Thank you very much, Prof. Fan. I think, Jeremy, shall we move on to the last speaker?
Yes, great. Thanks. So let me share the screen again for our next speakers.
So the final speaker for today is actually Dr. Arisara. Dr. Arisara is a cardiologist and instructor of Department of Medicine in Siriraj Hospital, Mahidol University in Thailand, and she will discuss sensing, arrhythmia detection, and SVT discrimination. Dr. Arisara, please.
Okay, good morning, everyone. And here comes the last presentations for today. So after you know the indications, you know how to implant, and now you have to know how does the ICD works. So the topic I will present today is about the algorithm and things for ICD. It will talking about the sensing, the arrhythmia detections, and discriminations. So here, what do we expect ICD? Need the ICD to detect the ventricular arrhythmia and need to give appropriate therapies when we detect arrhythmia. However, we need to discriminate from SVT because we don't want to have an inappropriate shocks. So for the perfect ICDs, what we aim for? We aim for detecting all ventricular arrhythmias. That means that we need the ICD to have a very sensitive for the VTs. And of course, like I said, the ICD should not treat on the SVT. So it has to inhibit their therapy if it's an SVT. That means that it has to have a specificity for the SVT as well. So for the ICD, it has to have a very accurate sensings. It has to have a good detection criteria and make sure that every criteria were met to diagnose a VT or a VF. It has to have a good discriminations between VT and SVTs, and then give therapies appropriately. So let's do a little bit of review. When we're talking about the sensitivities, it's abilities of the device to see a sense of the intrinsic signals. Comparing if you were on the other side of the wall, make sure that you will see everything you want to. So sensitivities is as a wall. And if you raise the wall up too high, you can see less. And if you lower the wall, you can see more. Same thing, when you have a VF or a VT coming in, you make sure that the ICDs see it well. Sometimes the amplitude of the VF or VT can go up and down. So that's why we need to set up the sensitivities as good. So like I said, raise the wall, you can see it less. Lower the wall and you will see it more. Before going further, you need to know about the leads a little bit. This is the ICD leads. And we detect the signals, we call it intracardiac electrogram signals. The ICD leads have tips and rings around here. And we have the coil of the RV or SVC coils here, which is a shocking coil. Why we have to know? Because they have to detect the signals, which is a EGM. We call a near field EGM when the detections come from the tips to ring. And this will represent the activations of myocardium at the tip of the electrode. Same thing, the coil here, the shocking coil here, will be able to detect the electrical signals as well. And the shocking coils will detect it when the coil to the cans are apart. So it will depict more obvious change in morphologies, and it will be resemble the surface ECGs. And this is for the example. This is a near field signal, and this is a far field signals. And you can see this is sinus rhythm, right? For the near field, when it happened to be a VT, is a very subtle change. It changed though, if you can see the morphology of the near field comparing to both a sinus rhythm and the monomorphic VTs. But you can see that if it's in the far field, it has an obvious change of the sinus rhythm morphology to the VT morphology. So the far field signals give you more change, and you can be easily noticed whether it's VT or not VT. So you need to have an accurate identify the arrhythmia, and that's mean that the ICD leads must be able to sense a small or large R wave. It has to sense the very small VF signals that following the large R wave. Don't sense the T wave, and don't sense the opposite chambers, don't double sense, and of course, don't sense any noise that's coming in. And that means it has to be very sensitive. So during the VF, as you know, the VF is a very rapid, low amplitude and sometimes low frequency signals. So if you fix the sensitivity or fixing the wall that you can see, and sometimes you can miss some of the VF signal like this. As you can see, the red line is the sensitivities wall. In sinus rhythm, the amplitude is pretty much the same, but sometimes in the VT or VF, the amplitudes can go up high and or come very low. So if you have a fixed sensitivities, it might be missed of the detections. So if you miss the detections and come under sensing, it can happen to failure to sense VF and have no therapies, or failure to treat VT and can accelerate to have VF, and result it can be fatal. So those ICDs have a dynamic sensitivity adjustment to make sure that they detect every signal that it should be. And these will be very, very sensitive. It's going to be auto-adjusting the sensitivity and threshold. So it look beat by beat, and let the time goes, and then they reset their threshold, and then they detect the next beat. Okay, so after the algorithm sense that there is the sensing coming in, the intrinsic signal coming in, the thresholds start, and when time passes, the thresholds drop, and then they have a decay. Make sure that they have a sense to the next threshold here. Okay, and this can prevent them from the T-wave oversensing as well. These kind of algorithm, we call it dynamic sensitivity adjustment, which have differ from each manufacturers, but every manufacturers of ICD have it. So in the general principle, it's the same for all ICDs in every companies. The name will be different. Like in Boston, they call it automatic gain control. For Medtronic, they call auto adjustment sensitivities. And for the Abbots, they call sense ability or automatic sensitivity control. All of these are the dynamic sensitivities detections. And for the tachycardia detections, if it's an EKG, with you all familiar with, the VTs, of course, you know that it will be a sudden onset. It has a regular YQRS complex tachycardias. It has an abrupt change in QRS axis and morphologies. And for the VF, it also has a sudden onset as well, but it will have a regular YQRS complex tachycardia. And this is the EKG. For the EGM, we need to detect as same as the EKGs, but the device needs to detect it well. So it needs to detect whether it's a fibrillations, it's a VT, or it's a sinus rhythm. It has to make sure that it knows right. So they have the criteria for the detections of the ventricular arrhythmia. These criteria were the rate and durations criteria. We set up the zones for the detections. We set up the discriminations that make sure that the device of VT to the SVT and VT from the onset, the stabilities, and the morphologies. And of course, if they have a dual chamber, they will have the AV associations criteria as well. Okay, so when you want to detect the VT, right, we know that it's a fast heart rate. So make sure that they have a rate criteria and duration criteria. They have to know how fast the rate is, so you can set it up, and then you will set it up how long that fast rate coming in, and then you will define the VT or VF. These will be measured from beats to beats. We call it interval or milliseconds, or beats per minute. And then we classify into zones, which we call it the VT zones or VF zones. And then we program it of the detections rate. Let's say VT zone, we begin at 162 beats per minute until 188. But if it's more than 188, we call it VF. So we define it ourselves, and we classify it into zones. Okay, when we detect these kind of rates and durations, they need to have a programmable, which are whether it's a consecutive beats by beats that they were counting that it come in fast. Let's say if it's a consecutive 16 beats in a row that come in fast, they will define, oh, it's in the detection zones at the rate that they were set to. So they will call it the consecutive beats, let's say 16 beats in a row. Or it can be probabilistic, which is a percentage or fractions. That's mean that you can tell them that, okay, if it's 16 beats in a row, let's say if it's 12 beats in 16 beats that come in fast, we'll call it, and you find it in the detection zone of VT or VF. Like this. This is a consecutive beats counter. As you can see that there are 16 beats in a row that come in fast, and the detection criteria is met. And that's mean that if it's met, it will classify it whether it's in a VT or VF, whether which one is in there. And for the probabilistic counter, they can have like a 12 and 16. You can all program. You can make it 8 and 10, 12 and 16, 10 and 20, whatever you can do. It will allows you to detect 12 beats of fast heartbeats in the 16 beats in a row. So you count 1 to 16, and then if there is 12 beats that it meets criteria of the fast heartbeats, it will detect as a VT or VF. And for the wording of sustain or non-sustain, it's the word that you define it to the device as well. So it's not like a real life that you were saying that non-sustain has to be less than 30 seconds, no hemodynamic change or something like that. But for the device, it's a defined word that you tell them what you call. So when they said it's non-sustain, it's mean that it doesn't meet the criteria of the VT. And if it's sustained, it might be less than 30 seconds, but it's met the criteria of the VT for the therapies. Okay, let's see how does the ICD detects the arrhythmia. Okay, first of all, they detect by rates. And with these rates, we program as a zone. It's a cutoff zones. So we can define it into VT or VF zone, like I said before. And we can tell them that VT zone, we might program in VT1, VT2, and a VF zones to make sure that we have defined a different therapy in each zones. So these are all programmable, like this. And then we can tell them that we can give them the monitoring zone in the VT1 as well. So you can tell that either zone that you define, whether it's going to have a therapy or it's just have monitoring only. And these will be based on rate and number of interval of the arrhythmia. Okay, so in each zones, like I said, you can define each zone whether you need a treatment or not. If you don't want a treatment, you just put it in a monitoring only. If you want it to overdrive pacing only, you can define it as an ATP only zones. Or you want to have a shocking zone and ATP or overdriving as well, you can also program like that. These zones are for patients that have many kinds of rhythm that coming in, and then make sure that it have a very good therapy and less pain. Okay, so in each ICD of each companies, you can program into 2 zones or 3 zones. This is up to you guys. Or you can program in just only 1 zone, like in those patients that have rugadas, you know that these patients have VF, right? So they have sinus, which is a normal zone, and then therapy zone at VF only. So this one will be just only 1 zone. Or some patients have VT and VF, you can define it into 2 zones, which in the VT zone, you can give overdrive pacing first, and then afterward, you have a shocking following, and then the VF, you have a shocking only, or you can program it in ATP during charging as well. And of course, for the 3 zones, you have VT1 and VT2, and then VF. And these will be more programmable, like in VT zone, you can put it in like measurement only or monitoring only, and you will see what it goes around there without any therapy at all. Or you can say this one is for ATP only, and the VT zone will be ATP and then shock, and then VF will be shock only. Everything you can decide. Okay, like this is an example of one zone that you give just only the VF zone. We turn off the VT zone. So from normal rhythm and go to the VF at more than 200 beats per minute or 188 per minute. It's up to what you program. And then you gave the joules that you want the patients to be shocked. Again, for the two zones, like I said before, that you have defined the VT and the VF zone, you can design as an ATP or overdrive pacing 3 times before you're going into the shocking zones. And you can upgrade each shock from like 25, 36, and 2 more of the 36 joules. Whatever you can do, you can decide your own therapy here. And for the VF zones, it's a shocking zones. Same as the 3 zones ICD programming. Okay, and here's the programmer, and you can see that you can design the therapy that you want in each zones. You can choose 1 zone, 2 zones, and 3 zones, and then you just design it. Okay, like this one, you have a VT1, VT2, and VF. Okay, and each of one have a 12 consecutive interval of detections. So from here, the device detect that there's a fast heart rate coming in. They count for 12 consecutive beats. Make sure that, oh, it's all fast. Greater than the detection zones, and then they give therapy upon which zone that it was in. If it's in VT zone, it will therapy as a VT1. If it's or VT2 zone or either VF zones. After each therapy, they have to make sure that the patients come to sinus rhythm or not, or it's still in arrhythmia. So it had to recheck always whether the patient's rhythm is in which side, sinus rhythm yet, or still in VT or VF. If it's in sinus rhythm already, it will call it sinus rhythm, and these will be detection by rates only. So if the rates drop below the detection zones, it will define as a sinus rhythm. Even though it's still sinus tachycardia or it's a slow VT, but it's not meeting that zone, it will define as a sinus rhythm because this is how they program. Okay, so here, this is a VT after they have the ATP, the VT terminates. And then as you can see here, it returned to sinus rhythm. So they detect that there is a bradycardia afterward. And this, they know that the redetections knows that this is the sinus rhythm already. In case it doesn't return to sinus rhythm and the arrhythmia is still going, the more therapy will be delivered. It's upon on which zone it goes in. Okay, so the ICD will again try to determine as a rate coming in, if it's the rate meets the VT1, VT2, or VF zone, and it will give the therapy. But the second time that they redetect, it will be earlier detection. From the first time that it was a fixed 12 interval of consecutive beats, the redetection will be shorter than that. It can program from 12 down to 6, or in VTs, it can programmable from 6 to 20. And the nominal setting is 6 for the redetection zone. Like this. This is a VT coming in, and it has an ATP going on already. After the ATP, the VT didn't terminate, and they found that the rate is still fast. So it gives in another therapy here is another ATP, and it's only 6 consecutive beats of detections. Not like the first time, it's a 12. Talking about therapy, they have 2 kind of things for the ICDs. The ICD can shock, of course, because the name, it's a defibrillator. And it has a base of a pacemaker too, so it can overdrive pacing as well, which we call anti-tachycardia pacing. So the shocking therapy, the amount of energy is able to program, and the maximum energy is always given to the VF zones. And we can program the maximum energy to appropriate in some VT zones as well. Okay, for the ATP, which is anti-tachycardia pacing or overdrive pacing, and this one we can program as well. We can program it short for a 1 or 2, or we can offer an extensive ATP in that zone without any shocks. And for the vert cardioversion, it's the same thing as a shocking therapy, but it's gonna begin with a lower than a maximum energy shock. Okay, so the ATP that I was mentioned is the same thing as an overdrive pacing, but the overdrive pacing used for the manual wording. So if you pace by your own, you call it overdrive pacing, but if it's auto, you call it anti-tachycardia pacing, which have 2 modes. They have a burst and ramp. The burst is a consistent pacing faster than the base rate of the tachycardia, around 10 to 20%, and you pace for a few seconds. You want it to pace to interrupt the tachycardia and make the fast heart rate to terminate and slow it down. For the ramp, it's a bit more aggressive. It's gonna accelerate the electrical pulse in every beat that you pace, so it's gonna be faster in every single beats. For example, like this. This is a VT coming in, and you can see that the device can detect a VT already and give the first burst of a consecutive regular pacing interval. And the VT doesn't terminate, so they give the second burst. And you can see that the rate of the pacing was constant, and luckily the VT is terminated down to sinus rhythm. Again, this is VT coming in. The device detect and give the burst ATP with a constant rate of pacing beats, and this terminate the VT. For down here, if you can notice that after the VT initiate and the device give the therapy, each consecutive beats of the pacing, it's faster, faster, and faster, and this we call ramp ATP. Okay, after you know how the ICD works, you need to know that ICD need to have a good SVT discrimination as well. Like we mentioned before, that we need the ICD to have a good detection to all ventricular arrhythmia and make sure that it inhibits the treatment if it's an SVT. So these SVT include AFib, A-flutter, and sinus tachycardia, or SVTs. We want to make sure that it will not shock upon these diagnoses. And because of the detections are based on the rates only, and sometimes the shock occurs and the patient will feel discomfort, pain, and you will eat up the batteries. For the inappropriate shocks, if it does happen, it will bring the patients to very painful distress and psychic trauma. Don't ask me how bad it is, because I never had a shock before. I just give the shock to the patients, right? But they were defined like it's as hard as a horse kick. Of course, I never been kicked by a horse as well, so I don't know, but it's gonna be very bad. But usually these patients, if it's a true shock, the patients might be syncope already, so they didn't feel it. But if it's inappropriate shock and the patient's in the SVT, they won't like it when they feel that they were shocked or punched out in their chest, of course. And in AVID study, there's 22% that the patients receive inappropriate therapies. And of course, the main reasons of the patients that get inappropriate shocks is the SVT, including AFib. Okay, so the ICD must have a good sensitive to detect the VT and have a very good specificity, so it will not chalk on the SVTs. Okay, so for the SVT discriminators, these ICD have to look for rates, both atrium and ventricles. They had to look on relationships of atrium and ventricular events. If it's a dual chamber, it's gonna be easy to look at the relations. It have to look at the regularity of the rhythms. It have to look at the onset of the arrhythmias, and it had to look at the shape or morphologies of the QRS complex. So for the beginning of the discriminator, each of the ICD begins with counting. So it counts the cycling of either atrial or ventricular rates and define whether which one is faster than which one. And of course, if it's in the dual chamber, you will be able to see if it's AV association or dissociations of the atrium and ventricular signals. And they need to know the interval of stabilities. When you want to know that it's a regular fast heart rate, you need to know that it's stable of each interval by interval. And when this arrhythmia occurs, if it's a true VTs, it has to have a fast change in heart rate, right? So these are abrupt change at sudden onsets of the tachycardia. And for the VT, again, the morphology and axis usually change. So these ICD have to detect the morphology change as well. When they do the rate counting, okay, if they have a dual chamber, they will be easy. So they will detect whether the V or ventricular rate is faster than the atrial rates or not. If it does, it will define as a probably VT. Like this one, you can see that the atrium and ventricular chamber, the ventricular chambers come much faster than the atrial chambers and make that the device detect that this is the VT because the V is more than the A. But if it's a 1-1 relationship, it's gonna be difficult and they might need the next discriminations criteria. For the AV dissociations, like this one, is a and the device check and then they know the A is more than B, so it's not gonna be VT. But in case of the AFib with RVR, sometimes it's gonna be hard to sometimes it's going to be hard to detect whether the rate that match the criteria already, whether it's a VT or AFib with RVR, and that it can cause an inappropriate shock. So if you have a dual chamber ICD, it will be easier for you to have a discriminator in AV dissociation. Next will be the interval stability, like I mentioned before. Usually in VT, we call it a regular wide complex tachycardia. So the regularity will tell you that it's a stability of the fast heart rate, compared to the AFib, which is a regular heart rate. So these will be detected in each interval, whether it's how much change in interval from interval to interval as well, and make sure that it's a subtle change or is a lot of change to define it's a stable or it's not stable. Like this. You can see the fast heart rate coming in. These are the near field and telling you that it's a fast heart rate and it's V more than an A. And you can see that it's a very stable one. So the interval stability meets the criteria. But for this one, if you know that this is the atrial and ventricle, if you have a dual chamber ICD like this, the ICD will know that the A is more than the V. So of course, it doesn't meet the criteria for the VT. And if you look at the stabilities, you can see that the ventral signal here, the interval was not stable at all. So it's able to detect that the interval is not stable and it doesn't meet the criteria for the VT, and it will define as an AFib. Next will be the onset. Each of the tachycardia has to discriminate how the onset occurs. Is it gradual onset or is it a sudden onset? For the sinus tachycardia, of course, it's a gradual onset of the physiologic response, right? And for the VT, it's a typically sudden onset. So looking at this, you can compare that when it was in the sinus rhythm and abruptly had a sudden onset of tachycardia, the interval changed abruptly. The way that the interval changed abruptly here makes the discrimination positive for the VT in the term of sudden onset. Again, this is another picture showing you that there's an abrupt change of rate, and it will meet the sudden onset criteria. And if you look further, you can see that the interval of the fast heart rate is very, very stable. So it will meet the regularity or stability criteria as well. And since this is the dual chamber ICD, you can see that the atrial and ventricular association was V more than A, and this will all conclude as VT. And this is similar to that, but this is a single chamber ICD. So if you compare this, you can see that this is a sudden onset of a tachycardia, and it comes pretty much stable. No, it's yeah. So it's a sudden onset of tachycardia. But if you can see here, this is the atrial signal. So this is a dual chamber ICD, and this atrial here is V more than A. So this is defined as VT as well, with a criteria of sudden onset, V more than A, and stability as well. Okay. This is another example, if you can see in here, which is a far field, or you can see that the ventricular signals come pretty slower than the atrial signal here. So it's A more than V, even though it's a stable one, but then it will know that it's a sinus tachycardia. And next, and a very important thing, is the morphology of the discriminator criteria. It's about the morphology, how it changed from the template. So when the patient was implanted, the normal rhythm will have a record template. So like you know, it is an SVT. It comes from atrium down to ventricle. For the morphology, it doesn't change from the sinus rhythm much. So the SVT morphology were similar to the sinus rhythm morphology, comparing to the VT, which originated from the ventricle, and usually the morphology is much different. So the way the ICD think, it will store the templates of the baseline sinus EGMs, and it will compare each beat to beat, to see how much it's deviate from the baseline. If the QRS that come in fast match the templates, it will classify as an SVT. But if it's not matched at all, it will classify as a VT. So these discrimination criteria, they use many criteria to define. They will not use just only single criteria. So many of the criteria will point to whether it's a VT or it's a SVT. This is example. This is a sinus beats coming from atrium down to ventricle, and this is the local EGM at what you can see. When it has a ventricular arrhythmia, you can see that although this is local EGM and it had a subtle change, but if you look into the detail, in the sinus rhythm, it goes down first and it goes upward. Okay, but this one, it goes upward first and then go downward. So it changed pretty much. Although it's not a YQRS complex, of course, this is an EGM, not the EKG. So this morphology changed a lot. Okay, so this is how they compare. They compare both near field and far field morphology upon the template and see how much change on both near field and far field templates. And when they look, they will see how much percentage match. Okay, you can see that if it's not matched, it will indicate VT. If it match, it indicates SVTs. And these percentage match of the stored template is very, very low. So this called VT. Okay, so SVT discriminator by device use many criteria to meet the diagnosis. They begin with the rate, looking at the onset, stability, and morphology discrimination. If you have a dual chamber ICD, okay, you can see that there is association between rate of atrium or ventricle or not. But if it's just only singles, you cannot use this one. You have to use other criteria to help whether it's a SVT or VTs. After you have meet the SVT discriminations and about the zone setting, like we said in the before, we now program at the monitoring zones VT1, VT2, or VF. Okay. Usually for the VF zone, I mentioned a little bit before, we use it for the single zone for the patients that we sure that they're gonna have VF only, like those patients that have rugadas or long QTs with polymorphic VTs. Usually these patients were very young and we don't want to have the VT zones to make them have inappropriate shock. For other ischemic or non-ischemic patients, we can put them into VF and VT zones, and how many VT zones upon your patients. And if you want to have one of the zones to be monitoring zones, you can do it as well. Okay, so for our conclusions for today, how does the ICD work? It works automatically. It has to have a very good sensing for the EGM signals. Then after they detect an abnormal fast signals, it looks if it's the rate and duration meets the criteria or not. The detection zone meet the criteria. And of course, don't forget the SVT discrimination. The single and dual chamber has a little bit difference of the more discriminate in the A and V. And then after they detect, they give therapies of either shocks or anti-tachycardia pacing. After they gave therapy, they come back again to redetect and make sure that they don't miss arrhythmia if the therapy is not success. And of course, for last of all, these ICD have a pacing function as well. So it also can be had a backup bradycardia mode and also have the backup post-shocking pacing too. Because after shocking, sometimes the heart is stunning and it doesn't have a fast or appropriate heart rate. So the post-shock pacing can help it out for a few seconds to minutes. And after that, after the heart is recovered, it's gonna come back to their own rate. So this will be all for the ICD automatic function and how does the ICD thinks. So now it's up to you guys to make sure that you have a good setup to the patients and make sure that the patients will not receive any inappropriate shocks. Thank you.
Thank you very much, Dr. Arrhythmia, for your informative lectures and teaching us how to read the episode. Dr. Shah, do you have any things you want to add on to this topic?
Thank you, Dr. Arisara. Nope, absolutely a fantastic talk. I've not much to add, but we have a couple of questions here from the participants. One of the question is, what is the difference in terms of SVT discrimination of single versus dual chamber ICDs?
Okay, actually the discrimination, like I mentioned, they look at onset, they look at first they look at the rate, right? After the rate meet criteria, they have to make sure that this rate is SVT or VT by looking at their stabilities, regularity of it. They look at the onset, make sure that it's a sudden onset or gradual onset, and they look at the morphologies, right? But for the single and dual chamber, the differences is the atrium and ventricular signal. For the single chambers, you don't have any atrial signal to discriminate whether it's V more than A or A more than V. So for the dual chamber to be answered, it's going to be better discrimination if you have an atrial arrhythmia together with these patients. Let's say these patients have AFib or A-flutter along with their VTs. If you have only just single chamber, it's a very hard to discriminate whether it's going to be AFib with RVR or flutter 2 to 1 versus a real VT. So if you have a dual chamber, you can differentiate it with A more than V or V more than A. That's all. Other thing will be the same.
Okay, thank you. A second question here will be, in your practice, what do you usually set the stability and onset criteria to?
Usually it's depend whether it's a primary prevention or a secondary preventions. First of all, I mainly set up the rate first. Okay, I do calculate the maximum heart rate of the patients. Let's say the patient is 30 years old, Brugada. You're gonna feel that the maximum heart rate will be 220 minus their age, right? So their maximum heart rate will go 190s. So like these kind of patients, I goes up very high. I have only single zone of VF, and then make sure that it's not gonna get inappropriate shot because these patients are very active. I will not do anything with the, well, I will do default for the stability and the onset criteria because usually these patients is a VF and the zone is more important. For the VTs, those non-ischemic or ischemic patients that I know that they have VT already for the secondary prevention, I will define the rate of their VT first, make sure that I cover up their VT rates. If it's not a slow VT, that's going to be easy. And after that, I will see that what is the default. Usually I go by the default first. And if it does have a false shocks or misdiagnosis, then I will modify it later. Usually for the sudden onset, I will use the sudden onset more than stabilities. Yes.
Thank you. Jeremy, do we have time for one more question maybe?
Yes, please.
So there's a question here, perhaps Dr. Yu can answer this. Is there any specific criteria that you use in your practice to decide between implanting a single versus a dual chamber ICD in your patients?
Dr. Yu, please unmute yourself. Or how about Dr. Rizzo, or can also comment on this
Okay,
question?
yes. So between the dual coil and a single coil, because I'm one of the extractor, I found that a dual coil is more risky. So I will use a dual coil as needed. That means that if the patient is a secondary prevention, I will use a dual coil for them. But if it's a primary prevention or it's a very young age patients, I will usually use a single coil. And I will make sure that when I implant, if I use a single coil, the RV coil will go against the septums and make sure that it should be always work. Yes.
How about Dr. Cha, your practice?
So I mean, I completely agree with Dr. Arisara. I think with regards to the question about single versus dual chamber ICD, I think the most glaring indication for a dual chamber ICD will be a patient who fulfills criteria for an ICD, be it primary or secondary prevention, as well as the patient having requirements for pacing. So for example, if it's someone with a complete heart block and also has a poor LV ejection fraction, then someone like that will probably benefit from a dual versus a single chamber ICD. And all the other criteria will then be on an individual patient's basis, but the most important will be someone who needs both pacing as well as defib functions will benefit from a dual chamber ICD or even a CRT for that matter. So that's the practice that I have. So I think I'd like to take this opportunity to thank all three speakers for the excellent session that we had this morning, and also to thank all participants for tuning in. I'll now hand over to Jeremy to close the sessions and settle any logistics issues. Thank you.
Thank you very much, Dr. Cha, for leading today's webinars, and of course, all our speakers, Dr. Rizera, Dr. Van, and Dr. Yu, for all your efforts in preparing for all these informative lectures. And of course, all our attendees today, thank you very much for your time. Before I pass the time to Dr. Cha for giving us closing remarks, so I just would like to advertise for our next ICD Part 2, which is on 19th of September. And there are other lectures, which is more focusing on the programming part. So for today's, Dr. Rizera already mentioned about some of the arrhythmia therapy. So we're going to give you more details about the setting on all those algorithms, and also how to manage ICD storms. I hope I can see you on next 2 weeks later, the Saturday next 2 weeks later. So now, Dr. Cha, we have any final message for our audience, for all of us?
No real final message, but a very big thank you to everyone. And I hope that all of us keep safe during this period, and hope to see one another again real soon somewhere for a proper conference.
not on a computer, yeah, but face to face.
All right, thank you, and have a very, very lovely weekend, everyone. Thanks.
Thank you. Take care. Stay safe. Bye-bye.
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 Bye-bye.